All right, we're going to be talking about Chapter 10, Patient Assessment. This is from the Emergency Care and Transportation of the Sick and Injured, 12th edition. This is one of those JB Learning books. So, for this, I want to spend time on the main objectives of the chapter, which is learning how to assess a patient, how to keep yourself safe, things like that. After this, you should be able to understand, the scope and sequence of patient assessment, whether it be medical or trauma, the phases, components of patient assessment. I will not be going through a PowerPoint slide here. I'm going to hit you with the high points. So we're dividing this up into a couple different sections, such as scene size up, primary assessment, history taken, secondary assessment, and reassessment. Let's talk about it. So the scene size up, when you hear that word and that term come up, you're sizing up someone. Let's say you go out to the club and you feeling kind of froggy, you're gonna fight someone. Well, before you fight someone, you should size them up. Like, I can take you, or I'm gonna leave you alone. I can see that you might hurt me. And that's exactly what we're doing here when we're sizing up a scene, is that we're trying to see, are there things that can hurt me? What are the risk factors for me and my partner, my patient? What are the things that are going to be important for me to glean out of my 360 of this scene right here? Because we had an old thing we used to do at the fire department. We'd pull up to a wrecked car and be like, well, before we start jumping off in this thing and seeing, we have to see how stable it is. So we do a 360 walk around to make sure there's no risks, no hazards. We're not hanging off the edge of a cliff. So a scene size up is you gauging a scene for safety. And in that size up, you're taking note of, is the scene safe? Because again, we have an old saying in Atlanta-lations 24/7. If the scene becometh unsafe, thou shalt dippeth out. Amen and amen. But also, is there a tub of glowing toxic goo laying around? Is there someone with a knife walking around? These are all things I've experienced in my career. Hazmat spills or a psych patient with a blade on, so sizing up the scene is integral for your safety. So sizing up the scene, we're looking for how many patients do you have? It's important because you can really only handle one critical patient. Even super medic, if they show up on scene, can really only handle one, maybe two patients. So if we got a bunch of patients, now we need to call for more help. What about if the patient's in quickly moving water? Well, we need swift water rescue. What if a bridge collapses on somebody? Well, probably confined space rescue. We have to be viewing the scene for our needs. There might be a time where you're like, I don't know what I need. Then say that. Hey, I don't know what I need. Call your supervisor, call med control, talk to the old fire captain with a big mustache on scene. I promise you, he's seen a thing or two. What is that, a State Farm commercial, I think? I know a thing or two because I've seen a thing or two. Ask around. There is no sense in letting your pride get in the way. I've seen many non-humble providers through the years that really probably should have just been like, hey, I need some help. I've needed help. I've been doing this for a very long time. There were times I'm like, this is atypical. I've never seen this before in my life. The book didn't go over this. There's no protocol for this. I'm gonna have to get creative. So I'm gonna call for help. So sizing up the scene, I'm looking at making sure the scene is safe, making sure I'm wearing the proper protection, making sure I've got my gloves on, or if there is a tub of glowing green glue, I got my hazmat suit on if that is appropriate for your department. How many patients do I have? Do I need additional resources? If you're in an EMTB role, then you might need ALS. What if the patient's actively seizing in front of you? Well, your ALS paramedic can come and give an anticonvulsant such as Versed or some other type of benzodiazepine and stop that patient from convulsing. All you can do is watch, pray, and hope they stop. So might be times where you might need ALS intervention. And then again, you need to consider things like C-spine, because if the patient has damaged their cervical spine, we have to consider that C3 through 5 keeps you alive, is our saying. And that means that there is a nerve called the phrenic nerve in that area that if it's damaged, the patient will lose their ability to innervate and move their diaphragm, which is allowing them to breathe. So that we could see a slew of problems from that. So when we're looking at scene safety, though, we're looking at it not just being a one-time thing. We're looking at scene safety being a continuous thing. because a scene that was safe a minute ago can change like that. I've had it happen to me. Just about any provider you've met have will probably say something similar like, "Yeah, it was all cool till it wasn't." And then everything started popping off. Like maybe the crazy family member came in, or maybe, some other type of variable entered the scene. But it can change like that. And I said, my advice, if the scene becomes unsafe and you are now in danger of being harmed and possibly your life's in danger, well, observe Atlanta Lations 24/7. If the scene becometh unsafe, thou needs to dippeth out. Again, no one will think you're a coward. If somebody pulls a gun, most of us are going to run. Most of us are going to run from that because again, we're not police. We don't have body armor in a lot of instances, and we don't have traditionally defensive classes to teach us how to deal with an assailant like that. So our best bet is to cardio. Gotta go, bro. So no one's gonna think you're a coward. You know, you're not dressed for the party. If the house is on fire and you move into a building and it's suddenly on fire, you're not dressed for the party unless you got turnout gear. So you may have to move out of the scene at that point. It doesn't mean you're a coward. I've had students ask that question, would I be thought less of? No, you will not be if somebody pulls a gun and you dip out or something like that similarly happens. So with seeing size up, we are again evaluating all those things that are going on there, seeing what help we need, what resources could be, you know, available to us. Do we have multiple patients? Are we observing standard precautions? Is there violence? Are there hazards on the scene? These are things I need to look at as I'm going through this. Now, next, we want to move into our primary assessment. Now, primary assessment should be done in about 15 to 30 seconds. This is a quick look-see of a patient, see what their life status is. So at first, when we come on to the primary assessment, I want to form a general impression. Like as I walk up, what do I see? Is there a person laying flat on their back with blood squirting out of their neck, or is it someone there that is seizing actively when I get there? Is it a 65-year-old female sitting forward with her hands on her knees, tripod, having some trouble breathing, and I can hear it, the wheezing across the room. This gives me a lot of clues to form an index of suspicion immediately. So a general impression is my first look at them. Then I want to take and look at their level of consciousness. Are they alert? Are they verbal? Are they painful? Are they unresponsive? That's called the AVPU scale. AVPU. Are they alert, which is they're looking at you, they're tracking you like, oh, hi, I'm here. I called, it's me. Or are they verbal? Like they laid out, sir, what? Sir, what? So they're only responding to verbal stimuli. You stimulate them to respond. Either maybe it's drugs, maybe it's diabetes or a low blood sugar. It could be a number of factors, but the fact that they're responding on to verbal stimulation means that they're not completely all there. They're a bit altered. That's a clue. Next, AVP, painful. This is the patient that's just laid out, and they're only responding to when you do a painful stimuli, such as, the old sternal rub's always been a favorite of mine. Just again, make the knife blade here, and then just dig into their sternum. We're going to cause them just a little enough pain to get a response out of them. We're not trying to hurt them, but I do need to elicit a response. Because if you are unresponsive in some type of like coma, there's a reason why. But I need to ascertain is like, are you responding to pain? Because your body will respond to it. So are they responding to pain? Or are they, unresponsive to everything? If they can ignore my 300-pound like sternal rub, or some people like a trapezius squeeze. I've seen people do a nail bed squeeze. There's even some people like to push on the eyebrow right here and elicit a pain response. Whatever your service medical director is comfortable with you doing, that's your bag, baby. But if they're unresponsive to pain and they're unresponsive, now I need to change the game. Now I need to look, listen, and feel. I'm going to get down by their face, and I'm going to put my hand on their chest and my other hand on their neck and feel for carotid pulse. I'm going to look for chest rise. I'm going to listen for breath sounds, and I'm going to feel for a pulse on the same side I'm sitting on, and I'm going to feel for at least 5 seconds, no more than 10, and see if they got a pulse. If they don't have a pulse, The game has changed. This patient will need CPR immediately. This will be what's life-saving for them is CPR. So again, if they're unresponsive, I'm gonna look, listen, and feel. Looking for chest rise, listen for breath sounds, and feel for a carotid pulse. Again, we can find the carotid. If you find the trachea right here, slide right over to this groove. There should be a nice bounding pulse right there. And if you don't feel one, call 911 because you're a zombie. So we're going to ascertain if they are alert, verbal, painful, unresponsive. Next, we're going to run into what we call the ABCs. Now, the ABCs stands for airway, breathing, and circulation. Now, what I mean by that is that we're going to check their airway, like their throat meat, their hole here, their mouth. We're going to see if they have some type of obstruction, some type of issue with the tissue of the mouth. We're just making sure that airway is open because you've got basically one pipe that you breathe through, your trachea. And if the airway is stopped up, clogged up, or any other type of messed up, the patient will not breathe. They will die. So we're going to check the airway for stridor, which is a high-pitched crowing or whistling noise that indicates a partial airway obstruction. We're going to check it for gurgling or fluid that's in there. Like if there's none of us are fish, right? We'd have to suction that fluid out with our suction equipment. So we're looking at, looking for stridor, gurgling, and then we're looking for snoring. A patient with snoring respirations is most likely occluded by their tongue. And that tongue being in the way would mean we need to do some type of airway manual maneuver where we move their head to get that tongue off um, the throat meat to move their tongue out of the way of the glottic opening so that they can breathe. So we're looking for three things when I'm checking airway. Is it patent, which means it's clear and moving air really well? Are we looking for gurgling, stridor, and snoring? And again, in other chapters, we'll talk about how to actually fix those issues. But right now, we're looking for the airway. Is it open, patent, stridor, gurgling, snoring? Next, I want to check the patient's breathing. Their breathing. Are they breathing? That's a good question. If not, I need to breathe for them. And again, when we hit the respiratory chapters, we'll talk about ventilation versus oxygenation. But for now, we need to know, are they breathing? Is air coming in and out of their body? And when I check breathing, I want to listen and feel for rate, rhythm, quality. The rate indicating how fast, the rhythm, talking about the cadence of the in and outs, like the breathing pattern there. Again, breathing pattern is a good clue for if they have something else going on. A quick example of that would be a patient with high blood sugar, like a diabetic, will have a fast and deep respiratory pattern, indicating that they're in Kussmaul respirations and that they have a metabolic acidosis going on. And they could be in diabetic ketoacidosis. So this is a good indicator for us to be mindful of. Like there's clues all throughout your assessment. Now, can we grab those buzzwords, grab those symptoms, and help us determine a field diagnosis and a differential diagnosis that's going on? So with breathing, I want to look for the rate, how fast, the rhythm, which is the cadence and pattern, and then the quality. When I say quality, we're saying, is it a normal breathing depth? Is it fast? Is it shallow? I'm looking for what is going on with this patient's breathing so that I can make a educated determination on how to deal with it. If it's normal, don't need to deal with it. If they're breathing shallow and or not at all, I need to breathe for them. Again, I'm gathering this information so I can make a determination. But patients will die if they can't breathe. I think we can all agree on that, and that we need to, act quickly. Airway management is one of the most preventable causes of death in the pre-hospital environment. And it's because we're not catching airway problems quickly enough. We have to detect them early, aggressively intervene, and then we need to come back and do a cyclic reassessment, and catch if it's changed at all. So we catch a problem, aggressively intervene, and then we keep going back and check and make sure what we're doing is working. And if not, we adjust. Next, we want to check the patient's circulation. Now, circulation is indicating what their blood flow perfusion status is. So I'm going to check a pulse at their neck again. I'm also going to check a pulse at their radial artery down here in the wrist area. There's an artery down there. I'm also going to feel their skin because there's clues, and we can't leave data on the table. We can't leave money on the table. So when I'm checking their circulation, I'm checking for rate, rhythm, quality of their pulse. I'm also going to check for skin color, temperature, moisture. Now, what does that mean? Well, a patient that's in shock will exhibit, pale, cool, and clammy skin. That's because the body is going to protect the vital organs at all times. One of the first things that the body will do is to shunt blood from the peripheral areas, the skin here, and shoot it to the vital organs. So if they're pale, cool, clammy, that's an indicator that they don't have good perfusion status. They might possibly be in shock. So the skin gives me clues. What if they are, got a bunch of little bumps on them and, there's a bunch of bees flying around and they're itchy and stuff? Well, that's a clue that they might be having an anaphylactic or allergic reaction to a bee sting because the skin is red. It's got little hives on it. And it's a clue. We can't leave this data on the table. It's money on the table. So we're going to check for the rate, rhythm, quality of the pulse. Is the rate, is it within normal limits or is it, too fast or too slow? What is the rhythm? Is it beating normally in a, cadence of beats or is it irregular? That's a clue. And what about the quality? A bounding pulse indicates a heart in distress. A thready pulse or a weak pulse sometimes feel like a butterfly's wings. It's very, very faint, very weak. It means the patient's deteriorating in front of you. And then there's the normal beating pulse that feels like a normal pulse. Like, again, the best way to learn how to feel what a normal pulse feels like is to feel a bunch of normal pulses. Like feel your classmates, like, all right, that's what a normal pulse feels like. Listen to a bunch of normal breath sounds. And then when you hear an abnormal breath sound, that ain't right. Or when you feel an abnormal pulse, you can tell by all the time you spent with your classmates checking these normal pulses that something ain't right. It's skipping a beat. Or when I check the breath sounds, we're like, that sounds weird. There's a bunch of sound like water in here. That's a clue. We can't leave that data on the table. So, airway, open and patent, breathing, rate, rhythm, quality. Then we got circulation check, where we're going to check their rate, rhythm, quality of their pulse, and then the skin color, temperature, moisture. That should take about 15, 30 seconds. I know I took longer to explain, but you in the field, after you've practiced this a while, this is a 15, 30-second thing. We need to determine what their life status is. If there's a threat to their life right then and there, I'm acting on it right now. And after I've determined their ABCs, I will then determine a transport decision, which is, am I going to stay and play or am I going to load and go? Stay and play, load and go. Now, sometimes time is tissue. So like with a stroke patient, a heart attack patient, or a trauma patient, you got to be off that scene as quick as possible. Trauma is a surgical disease, which means it needs a surgeon to fix it. Yeah, at the paramedic level, I can, put a splint on. I can give pain meds, and I can be like, oh, they're there now. But I can't reset the bone. I can't put screws in it. I can't put a cast on it. And I can't write a script for Percocet. They need their doctor for that. A patient with a stroke needs a stroke center. A patient with a cardiac MI or heart attack, myocardial infarction, they need to be at a cath lab. Getting that plug pulled out, getting that clot out of their heart, or something to go around it. So these are time sensitive. So stay and play is an option for some times, but also most of the patients we run that are serious, that's not a stay and play. That is a load them and go. There's a lot of things you can do en route that'll save your patient time. We are to prepare and package them for transfer to the ER. As much work as I can do for that ER staff to help that patient along the way, I will do. At the paramedic level, if I can give drugs to help the patient stabilize for them, I will. If I can give an IV so they can draw labs, I will. If I can go ahead and send my 12 lead of their cardiac rhythm to show that they might be possibly having a myocardial infarction or heart attack, I can show the location and the, infarcts area and how bad it might be. They can see that. So my job is to package the patient. It is to stabilize the patient. It is to, again, get them to tertiary care or final care as quickly as possible, as possible. So again, I'm going to check those vital functions in that area, and I'll begin interventions there. Now, once I get past the ABCs and I've made a transport decision, either way, the next step for me is I've got to gather more data, right? I've got to gather more data on this patient's history. I need to determine if they got a chief complaint like my foot hurts or I can't breathe. That's a chief complaint. That is a number one in your face complaint that is occurring. So I want to determine what their complaint is, and it can help me figure out what their field diagnosis is. In pre-hospital, we're not allowed to really diagnose patients, but I do believe in our assessment drives our treatment. Like, I don't just give medications prophylactically. I don't give them just because I feel like it. I do it because I see a problem. I don't know if this guy's got asthma. He's breathing so bad I can't hear him speak. He can't get a word out. Well, I don't know if he's got asthma, but I do know he's got some bronchoconstriction. I do know he's wheezing pretty hard. And I know that he needs a drug to bronchodilate or make his lungs a little bigger in there so he can get more air in. That's a problem. I can see, I can hear, I can treat it. I'm not Superman. I don't have x-ray vision, but I do treat complaints and symptoms that I see. But I have to, again, be looking for these things. So, chief complaint, I want to determine if they have a mechanism of injury, which is a trauma thing. What is the occurrence here? And or the nature of illness. Is the nature of illness some type of pulmonary issue that they're having trouble breathing or cardiac? When I talk about mechanisms of injury, I'm saying trauma, like car versus tree, and then you see that there's a big spider web on the windshield. That means that there is something has hit it. Then you see the patient has blood trickling down their forehead. You put one and one together, forehead bleeding, spider web windshield, possible head injury. It gives me an index of suspicion. Now, what other signs and symptoms can I see? Do they have any allergies? What's their past medical history? What kind of drugs are they taking? What was the last time they ate? And then what's the story? That's usually the most fun and interesting part for me is the story. Like, how did you get this to happen to you? You'll find when you start your career some very interesting stories. I loved a good story. A difficulty breathing is a difficulty breathing. A cardiac arrest is a cardiac arrest. After some years, they kind of blur. But every now and then, a good story pops out and it makes it very memorable. So the people are infinitely interesting to me. So the story. So one of the ways we can remember that is we love mnemonics in EMS. You may have learned that already. Is the sample mnemonic, SAMPLE, sample. Now, when we take a sample history for a patient, we say S stands for signs and symptoms. A sign is something you can see, you can touch, you can hear. It's blood pressures. I can see they're having trouble breathing. I can hear wheezing. A symptom is something the patient tells me they have. Hey, bud, having trouble breathing, nudge, nudge. Or my foot hurts. Whatever it is they tell you, that is their symptoms. A sign is what I can see. Now, we said sample was A as allergies. Before I give a drug, before I do an intervention on a patient, I need to know what they're allergic to. If they're allergic to latex, and I'm over here on their face, like, I love my latex gloves. Don't you like them? No, I'm allergic. Oh, well, that's a problem, isn't it? So, or if they are having a heart attack, and one of my protocols says, hey, give this guy aspirin. It's good stuff. I'm like, well, here's some aspirin. I'm allergic. Oh, well, now we have two problems, heart attack and allergic reaction. I have to see if these people are allergic to the medicines I'm giving. Also, I get this information out of the way for the ER to speed up their time of treatment. Trying to help out here. So, signs and symptoms, allergies. SAM, M stands for medications. You do any drugs, sir? Hmm? Do any drugs? Now, there are drugs that are assigned by a doctor. These are your prescribed drugs. And there's also, do you do any drug, like a good, like street drugs that you get from a dealer behind the 7-Eleven? These are questions you're going to ask. And you don't want to be rude about it because people will be turned, hey, look, I'm not a cop. I don't care. But if I give you medication, it could interact with the medications you might have taken. I would just like to know, do you have any prescription drugs you take? Do you have any street drugs that you might have taken that could be causing this problem? Working in Atlanta for many years, like I did in the 911 systems there was illicit use of some street drugs. And it was a common question. And a common answer was, oh, yeah, I did a whole 8 ball. I'm like, my man. Because we're not here to judge. Like, I mean, it's your life, you live it. I treat what I see. And again, giving me the right information helps my treatment and helps me determine a cause. I pull up guys sitting there scratching and itching like, it's real hot in here. I'm like, buddy, it's the middle of winter. I got 3 coats on. He's like, and he has no shirt. He's like, I said, buddy, you done any drugs? A little bit of crack. I'm like, Okay, that makes sense. That's why your chest hurts. He called for chest pain. His chest hurts because he did crack. Well, that again, not judging him, but here we are. Now I know why. Then when his vitals are through the roof and his blood pressure's through the roof and he's having a lot of issues, I can then determine that he might be in a sympathomimetic toxidrome, and I can treat it appropriately via my protocols and medications pharmacology that I have. That is good information. So the medications they're on, prescribed, it can also help me tell me like what history they have, or non-prescribed that they decided to take. Now we said SAM, sample signs and symptoms, allergies, medications. P is pertinent last medical history. So pertinent history means medical history that would possibly be pertinent to what's going on today. Like you having a hysterectomy in 1920, while it's part of your history, it's not pertinent to what I'm doing today. So asking, do they have any medical history, such as have you had any heart attacks? Do you got high blood pressure? Do you have high blood sugar? Do you have low blood sugar? Like finding out what kind of history the patient has can help you determine the illness that they have and the manifestation of symptoms that they're showing now. A lot of times they're related. You know, metabolic derangement secondary to these medical problems is very common. Like I'm running an altered mental status. Oh my God, he's got diabetes. Let's check his sugar. It's 40. It lines up very well. The problem we're having today is because of the lifestyle choices and the medical history this patient has had for years. Again, I'll only know that if I'm asking the right questions. And again, EMT, AEMT, paramedic, whoever, I wouldn't be giving drugs or doing a whole bunch of interventions unless it's like life-saving interventions without gathering the data. Data drives decisions for drugs, especially if I'm your instructor and you're in paramedic school or EMT school and you're about to give a drug and you haven't taken a history. I didn't plan for the patient to be allergic to aspirin, but if you didn't ask if they had allergies and you give it, I'm suddenly going to make them allergic to aspirin. Teach you a lesson. But it's a lesson I'd rather you learn with me than on the streets. Please ask for data before you make decisions about giving drugs or doing interventions. Gather the data, again, unless it's a life-saving intervention you have to do. So we said SAMP, past medical history. What about L? Sample. L stands for last oral intake. That's important for several reasons. A couple of examples I can give is like if they are a diabetic and they didn't eat breakfast, but they did take their insulin, insulin drives blood sugar down. They didn't have any carbs in their system to balance it. Their blood sugar dropped. No wonder they're altered. Or if they've been in a bad trauma, they might need to go to surgery and they'd want to know, have you eaten anything in the last couple of hours? That way we can, make sure you don't aspirate and puke up KFC on us. Several other reasons exist too, but you get the idea. When do they last eat? It's an important concept for us to note and to notate. Now, the last one is the E, sample E, SAMPLE. E is events that led up to this event. What is the story? This is my favorite part. How did you wind up here? How did you wind up doing this? Again, very interesting stories. It's my favorite part is like, what's the story? Tell me what happened. And again, you know, well, I called for chest pain and I think it's killing me. I'm like, buddy, you're 17. It's unlikely, but you could be having a heart attack. We never know. Because again, we can't play God in the field. Only way to really tell if a patient's having a heart attack is by drawing labs on them, looking for their troponin levels. I mean, we can look on an EKG, but a lot of patients don't even have EKG changes when they're having a heart attack. Well, I just had I went to Buffalo Wild Wings. Oh, you did, huh? Oh, yeah, you tried the Buffalo hot sauce challenge. So, not saying that they're not having a heart attack, but the fact that they went to Buffalo Wild Wings, had a whole bunch of spicy wings. I know personally, I would have to do a pregame with some Tums before I go eat wings. In your mid 30s, not like I'm in my 20s anymore. Like I'm gonna eat wings, still gonna do it, but I got to pregame with some Malox or something. So I can take the history of the patient and help me determine my field diagnosis here. Again, E is the events of what happened. Now, after we have decided on, taking this history with the sample mnemonic, I can then decide if they're in any kind of pain. I can look at another mnemonic we'll learn called OPQRST. O stands for onset. P stands for provocation or palliation, what makes it better or worse. Q stands for quality. Again, we're looking for like a descriptive adjective to help me determine, the type of pain it could be. R stands for the region or radiation, like where does it hurt? Does it move anywhere? S stands for severity, and T stands for time. If they're in pain, we'll go over those to determine what type of pain it is and if it's got some other underlying cause. Here's a quick example. Patient calls for chest pain. It started about 10 minutes ago. Okay, that's O. Does anything make it better or worse? No, nothing makes it better or worse. All right, can you describe the pain to me? Yeah, it feels like a horrible tearing sensation in my chest. Okay, does it radiate anywhere? Does it move anywhere? It moves to my back. Okay, you have a substernal chest pain that feels like a tearing sensation that radiates to your back. Now, guys, if you're already picking up on this, that's an indicator of a possible AAA, an abdominal aortic aneurysm. This is where the aorta itself is starting to have a bulge that might be leaking. And if it bursts, that patient could die. I mean, they could be on a surgeon's table and still maybe not make it. That's a big artery right through there. And if it bursts, it's feeding all these arteries elsewhere. Patient could likely die. This is a very serious emergency. So the next we would do what is the severity. It's a 10 out of 10. And then time, like how long has it been going on? 10 minutes here. So now I have an indication of a possible AAA by, again, asking this OPQRST. I was able to further determine history taken and see what type of issue it might be. Now, the next thing I need you to do is do a full body scan. This is your secondary assessment. With a secondary assessment, we're going to do a rapid full body scan. We're going to focus on assessments of pain if you need to. I believe in doing a full body scan on everybody. Trauma patients get a full head to toe. That way you don't miss anything. But even medical patients, I'm a big fan of going head to toe. It only takes another minute or so. But the thoroughness of this is that I can find insulin pumps, fentanyl patches, open septic wounds, or nitro patches. Because I've been thorough through the years, I have found patients that have had those type of issues go on. That's why I tell all my students, be thorough, even on medical patients. Now, if guys at a skate park falls off of skateboard, twists ankle, you can focus on the ankle. I'd start there, but then I'd do a full body scan to see nothing else was going on. Personally, I'm a big fan of 12 lead in everybody, blood sugar in everybody, and full body scan everybody. It don't take but a second to run it over a minute and just see what's going on, you know? So then we can assess some vital signs. Now, vital signs we're going to talk about because it's important to know where people are at. We want to get that first baseline set of vitals. That way I can trend them. Now, trending means that I'm going to see, is the patient getting worse or better? Is my treatment making them better? Is it making them worse? Or are they just deteriorating naturally due to the circumstances of their medical emergency? That's also a thing. So I want to evaluate their level of consciousness, their blood sugar. I want to evaluate their blood pressure, their pulse, rate, rhythm, quality, their pulse oximetry, how much O2, what their O2 saturation is. I also want to evaluate possibly an EKG rhythm if you're on the medic level, and if not, maybe get your medic to put an EKG on them. Doesn't take but a minute. I want to evaluate all these things. So again, blood pressure, pulse, O2 sat, respiratory rate, blood sugar, LOC again. I want to again evaluate all these things to see what is off. Again, we're looking for pattern deviation. A normal heart rate runs 60 to 100. If it's over 100, the patient has tachycardia. Why are they tachycardic? Are they just excited to see me, or is there something internally going on? What is the pattern deviation? I have to set a baseline set of vitals to determine that. Within that secondary assessment, I also want you to think about taking breath sounds. Now, I'm a big fan of doing breath sounds earlier, like when I'm ABCing. Go ahead and get that out of the way. Let me go ahead and listen to breath sounds. But either there or here during your assessment, I'd be listening to breath sounds. You need to know how they sound. Are we missing one? Is one of the lungs out? Somebody that's been hit in the chest by a steering wheel because they crashed into a tree, they might be missing a lung sound. They might have popped a lung. We need to check for that. Somebody that's got a history of asthma and is sitting there wheezing, you might want to check for that. So again, we're going to be looking for a full body scan at this point, checking every system like the respiratory system, the presence of breath sounds, cardiovascular system, listen to heart tones, checking their stomach, for types of any types of injuries or normalcy. Checking all anatomic regions. So again, we're going to check blood pressure, pulse ox, the pulse. I'll really want a blood sugar on everybody. I'm a big fan of going over it again. Now, I also want you to consider your reassessment for patients. Now, the National Registry answer for this is that for a stable patient, you can check them every 15 minutes. For an unstable patient, every 5. That is a National Registry test question answer, and that is what you'll put on your test. Now, here's what I'm saying. I don't really take my eyes off a patient. Patients do not suddenly deteriorate. You will suddenly notice. I've seen medics back there so concerned with their documentation, they didn't notice that the patient was slipping into heaven's gates. So it's important to keep your eyes on these patients. Hey, remember, a day at work for you is a life event for these patients. Most of us could think about that. If you've ever had to call 911, the day you call 911 is a life event for you. Like I remember that vividly. So we have to be able to do a great job with this. And again, the test question answer, 5 for unstable, 15 for stable patients. But I'm telling you, go back to LOC, check their ABC, check your vitals and interventions, and keep cyclically doing that, looking for any changes to what's been going on with the patient. I'm a big fan of just continuously doing that. Now, I'm not telling you not to do your paperwork. Let me tell them I said not do your paperwork. I'm saying focus on your patients because people come before profit. People come before profit. Again, you might work for a private service. You might work for a local county government service, such as the fire agency. I don't care. People come first. You are a patient advocate first. You are a patient advocate first. Put those people first. Keep your eyes on them and prepare yourself and watch for any changes that they may have coming. So that is the highlights from chapter 10. I mean, there's a lot more fluff in the chapter and in the PowerPoint slides and stuff. And I do hope you attend the live lecture and catch all that. But this is, again, for you if you want to review or if you want to watch this and get the highlights, the nuts and bolts, as it were. It's here available to you. I'm always available for questions or anything else you guys might need. Other than that, you have a great day.